So we're here continuing to speak about research papers and trying to pull possible clinical applications out of them. So the paper that we're speaking about will be linked to below. What we're talking about from this paper is the concept that if there's uncertainty about motor task goals, okay, so let's just say presented with multiple possible targets, I don't know which one's going to light up, right? I don't know which one I'm going to have to touch or to tap. I'm going to make multiple motor goals, right? So say I have 3 targets, I'll have a goal, 3 motor goals, and my planning will essentially, I'll only be able to execute one actual motor plan. So that plan will tend to be more midline, so it'll be more in the middle, so if I have to deviate to one of those 3 targets, I can. So I have multiple goals, but one plan. That plan is probably going to be intermediate. Now, why would this matter? Why would I be attempting to pull anything from information like that? So we talk about our concepts of patient positioning and the idea of palpation. So we know that palpation in manual therapeutics is generally displays poor accuracy, right? So depending on the study that you look at and depending on the BMI of the patient, as is noted in most patients, we run from about 20 some odd, so low 20% accuracy, up to as high as 85, 86%, depending on the study you look at. That's problematic, right? So our actual accuracy in palpation in manual therapeutics is not as trustworthy as we would like, and that's why I will say things such as specificity is not the #1 necessity. Movement is. Move from the known to the unknown. Get as much as you can touch, because I understand that palpation accuracy is somewhat poor. So why would a motor goal or a motor plan in an uncertain situation be of interest to somebody in manual therapeutics? So one of the concepts of patient positioning is I would like the anatomy exposed, free to move in the plane required, and preferably visible. Now, if I wanted to do something to the patient's vertebral column or scapula or the sacrum for whatever reason in lateral, and I'm standing on this side, although it is exposed and free to move, all these structures are exposed and free to move, especially in the transverse plane, I'm going to have a hard time seeing them. So what I have at that point is some uncertainty. So I have problems with palpatory accuracy just built into the whole kind of pie, but I also have some uncertainty because I don't know exactly where my target is. Right? I can't see my target, and that's why we want to talk about the concept of something being preferably visible, and that moves into the concept of multisensory integration, which we've spoken about. So if I wanted to palpate through the patient's T-spine, okay, what I have to do is I have my motor goals. I want to identify the T-spine, but I also have to understand that I can't see where the T-spine is. So what we get oftentimes is because there's uncertainty in the actual outcome, there's uncertainty in where I'm going, we get what some people may term jokingly the tabby cat hand. So, you start pawing around on the patient. For some patients that's a little uncomfortable because it seems like the practitioner doesn't know where they're going. So how would I approach this? How can I go ahead and use this concept? Well, where is my goal? My goal is going to be somewhat in this region. So I can subsection the patient's body. I know that I can identify the ribs, I can identify where the top of the neck, or where the bottom of the neck is, the top of the T-spine is, and I know that I have some depth perception, whereas if I reach forward, I can see the table, so I know that it's somewhere in here. So I know that if we're moving from the known to the unknown, right, so we've got the thorax, generally speaking, in this region, I can identify that visually. I can then go ahead and start to reach posterior to the patient. The problem being that if I reach short, right, so I need to understand if I reach short, then I'll miss it. So I have uncertainty here, I have lots of uncertainty. So what I'm going to do is use that concept of moving from the known to the unknown and get as much as you can touch, use broad contact. So if I see the shoulder girdle up here, what I can do is I can overshoot on purpose. I can try to reach farther down the table. I can identify the T-spine. Now the T-spine happens to be, I can't see it, but it happens to be right in around here on my fingertips. So I've identified the T-spine now. Now I can match. So I have something known. So I've moved from the known, right, shoulder girdle, inferior angle of the 12th rib or inferior border of the 12th rib. I've moved from known quantities that I can visually see. I've made a motor plan that has a goal, right? So I've created my goal. I'm going to use my the patient's shoulder girdle as my contact point or as my initial starting point. I'm going to purposely overshoot because I know if I go too far and I wrap around and I have my forearm and my hand contacting a large surface on the patient's back, I can identify the T-spine. I will come into contact with it. Now I have something else known. So moving from the known to the unknown, I can match. Now I can palpate through the patient's T-spine. How will I know when I get to the bottom? So if I'm doing something like this, I could still think, say I start here, I start low in the T-spine. If I'm doing this and I'm not looking, I'm missing, I have task uncertainty again. I could start to think that this is the T-spine down here, when in reality it's the lumbar spine. So this is why we talk about using our eyes as well. All right, so again, moving from known quantities because there's uncertainty here. Having a motor goal, or maybe multiple motor goals, but understanding that if I behave this way, I'm going to miss. I'm going to have a lot of uncertainty. This way, what I will actually end up doing is kind of shortcutting it, purposely overshooting, purposely utilizing that concept of moving from the known to the unknown, that concept of get as much as you can touch, and I'll be able to identify what I'm looking for. But my life would be much easier if the patient happened to be facing the other direction and I happened to be sitting down, so I was closer to the area I want to work in visually. When I can't be, when there is uncertainty, such as when a patient is in supine and I want to work on the vertebral column, or I want to work on something on the posterior surface, I have uncertainty. But what I'm going to do is use things that I understand. So having my motor goals, I'm going to go from a known region into the region I'm looking for, but I'm going to start to narrow in, and I'm going to use all of these concepts that we've spoken about here in order to make my life a little bit easier, and also so that I'm not pawing at the patient and acting like a tabby cat.